My name is Cristina Antonescu, and it's a great pleasure for having you back here at Memorial for the GCRF award presentation. We worked really hard to put together a packed program for you today. We'll start with our first presenter, Chiara Kelly, who's going to talk about her recent work on next generation sequencing in GIST.
Good afternoon, everybody, and thank you for the opportunity to present to you all. I would like to present on behalf of myself and Timothy Bowler, a co-fellow who we've been working on this research together with many other members of the sarcoma service. And our talk is entitled Routine Next Generation Sequencing in the Management of GIST. And what is next generation sequencing? This is a sophisticated technology that thankfully we have available at Memorial Sloan Kettering that allows us to examine tumors, to look at their molecular makeup, and guide us regarding potential management in the future. And GIST have become a paradigm for the use of molecular diagnostic tests. And the reason for this is that the majority of them have activating mutations or genetic changes in KIT or PDGFR alpha genes. And actually, GIST is really the poster child for what we call personalized cancer medicine, whereby we identify a genetic change within a person's tumor and then we target that with a specific drug, such as Gleevec in the setting of GIST. And this pie chart just reflects the molecular subclassification or categories of GIST. And so there are many more than KIT and PDGFR alpha. There are many others, more rare variants associated with genetic changes in genes such as NF1, SDH complex genes, BRAF. And why is it important to understand or classify these tumors? Well, it can inform our therapeutic decisions, but also give us prognostic information and tell us maybe how these tumors may behave. And it's important to know that the molecular makeup of the tumor may change over time and after exposure to treatments. And in the setting of KIT mutant GIST, we see that in tumors that progress or grow in the setting of Gleevec, many of them are found to have secondary KIT mutations which develop in other regions of the KIT gene, such as in exon 13, 14, 17, and 18. And we have learned that these secondary KIT mutations correlate with therapeutic efficacy with many of our treatments. And the graph depicted on the left-hand side of your screen shows patients that were exposed to sunitinib. And we see that patients were then stratified depending on the secondary KIT mutation that they may have had. And we learned that patients with KIT exon 13 and 14 mutations were benefited from the medication for longer than those patients with KIT exon 17 and 18. And it's also very important, particularly now, because we are in the midst of new novel therapies that are currently in clinical trials and thankfully open at Memorial Sloan Kettering. They're either open or opening very shortly. There are a number of new treatments that are specifically targeting secondary KIT mutations or a specific PDGFR alpha mutation. So therefore, it's really important that we know this information to help us treat our patients and select the most appropriate treatment for them. The precision medicine strategy at Memorial Sloan Kettering is really focused on MSK impact. And what is this? They've developed a next generation sequencing assay, a test that encompasses 468 cancer-related genes, so quite an extensive gene panel. And how is this performed? We get tumor material from, let's say, a previous biopsy or surgery, and then take this and together with a blood sample, look at the DNA in both of these specimens, and then we perform the next generation sequencing test on both of them. We then identify the genetic changes specific to both of those materials and compare them, and we can find out what's specific to the tumor. And then the report is entered into the patient's medical record and there for the physician for the future to help them hopefully guide them regarding subsequent treatment decisions. So this test became available in the form of on a clinical trial protocol at Memorial in 2014, and we really have started routinely performing this test in our GIST patients. And so we decided to undertake a study to look at how the molecular information we get from this test may help us treat our patients, and then also look at the molecular changes in GIST beyond the known genetic drivers such as KIT and PDGFR alpha. And so we identified 177 patients who had had this test performed just over a 2-year period. And then we looked at their medical records to help discern how the next generation sequencing findings influenced management. And then we looked at the next generation sequencing findings in a bit more detail to beyond the known drivers within GIST. And we identified, we had 191 samples were sequenced from those 177 patients. Sequencing was most commonly performed in patients with advanced disease. The primary tumor was the sample type most frequently tested in 63%. And I'll touch on this in a little bit later, why this is important to note. And the next generation sequencing findings, the results from MSK-IMPACT came back within, on average, 21 days. And this pie chart then reflects the molecular subclassification of the GIST patients that were in our study. And so similar to the last pie chart I showed you, in that the majority have KIT exon 11 or exon 9 or PDGFR alpha mutant GIST. However, we do have quite a larger proportion of patients with SDH deficient GIST, NF1 related, and this probably reflects the fact that we're a referral center for GIST and that we'll see these rare variants probably more commonly than other centers. So did MSK-IMPACT testing guide our management? And it did in 80% of cases. And really, we expected this. This is what we expected to find because almost 80% of these tumors, 80 to 90% of these tumors have what we call targetable genetic changes such as KIT or PDGFR alpha. And therefore, in the majority of the cases, we recommended standard therapies. However, there was about 10 to 15% of the patients where we did not recommend targeted therapy because there was no genetic change evident in their tumor to warrant it. And then another 10 to 15% of patients, we offered a clinical trial, utilizing that information to guide us which trial may have been the best, a targeted approach versus perhaps an immunotherapy-based trial. And in 18% of cases, we found that the MSK-IMPACT results really didn't inform our management. And for the most part, again, we expected this because the majority of those were patients who had GIST tumors removed with surgery, were deemed to be low risk, and therefore therapy after surgery was not indicated. So then briefly looking at the molecular landscape of GIST beyond known oncogenic drivers such as KIT or PDGFR alpha, we essentially have broken down our GIST cohort into each of the specific GIST molecular subgroups. And this is for a snapshot of one of them, the PDGFR alpha D842V driven GIST. And here I highlight the 15 samples that we have in this cohort. The primary samples are reflected on the left and the metastatic samples on the right. And what you see here are the genetic changes that we observed in these samples. And what can we learn from this? This is quite a small cohort, so it's hard to see any specific patterns. But we will add to this, and what we're looking for is to see, are there any genetic changes that we can maybe target with an alternative therapy, or are there any changes there that can inform us regarding why the tumor grew in the first place or why they've stopped responding to a therapy. And so we've looked at all the cohort, broken them down, and I'm going to be presenting more work on this next week at the weekend at our annual ASCO clinical oncology meeting. So looking to the future, molecular characterization of GIST currently requires material from an invasive biopsy or surgery. And naturally, there's reticence to repeat biopsies in the setting of when a tumor progresses on Gleevec, for example, to identify the new molecular changes that may be apparent in the tumor, because we don't want to subject our patients to invasive biopsies unless we absolutely need to. But now that we know, when we're beginning to learn even more so, that the molecular information from GIST guides our standard therapies, and currently also now our investigational therapeutic approaches or therapeutic choices, we really do need to know this information. And the ideal, therefore, would be to identify a less invasive approach to determine these molecular changes within GIST in a serial fashion, such as from a blood test. And so, under Ping Chi's guidance, together we have been trying to develop this here at Memorial. And with time, tumours can shed some of their genetic makeup into the bloodstream. And this can be potentially captured in something called cell-free DNA. And a blood sample would allow us to overcome the limitations of a tumour biopsy, which is invasive. It would also potentially allow us to capture the genomic complexity of the tumour. So a biopsy will just focus on one area of the tumour, but we know that there is heterogeneity within GIST tumours, and therefore a blood sample may be able to capture this to a greater extent. Also, we would be able to track tumour evolution and the molecular changes in real time. So there have been some studies already performed looking at molecular testing on cell-free DNA using older techniques. And they have been successful in detecting primary and secondary KIT mutations in GIST. And they've shown the ability to detect these mutations has been associated with the extent of the patient's disease and with how the tumour may respond to therapy. Therefore, molecular testing of cell-free DNA represents a minimally invasive approach to molecularly characterized GIST that requires further clinical investigation. And here at Memorial, we have been doing this, and we have been prospectively collecting cell-free DNA from many of our patients who have GIST that has progressed on Gleevec and has advanced disease. And we have performed MSK impact next generation sequencing testing on this material. And we've tested it in 50% of the patients where we've collected this material. And we have been able to detect tumor-derived cell-free DNA. And the next steps moving forward will be to optimize the sensitivity of our ability to detect the GIST molecular changes from a blood sample. And we're using the information from the study that I've just spoken about to help us determine a targeted GIST-specific panel. And then the next step is to move this into the clinical trial setting, which we've already started working on as well. So exciting things for the future. That's it.
First of all, I'd like to thank Tanya and Bob and the GIST Cancer Research Foundation for their continued support. And most importantly, I'd like to thank the GIST patients and the GIST community for their courage, motivation, and really support for us to continue both research in the laboratory as well as in the clinical settings. Now, following Kiara's steps, I think she's done a wonderful job of introducing the different variety and spectrums of the mutations and the mutational landscape in GIST. So I'm going to sort of come back to some of the very fundamentals as we think about GIST. So beyond the genetic alterations that we have observed, we know for a long time that GIST comes from the precursor cells called the interstitial cells of Cajal. These are the pacemaker cells of our GI tract. They help to control the synchronized motion of the GI tract to move the food along. So a very important subset of cells. When these cells get mutations, some of them, many of them, as Kiara had described, especially KIT mutations, and then they become, eventually become malignant, transform into the so-called gastrointestinal stroma tumor. And now we know, so this is actually a very simplified version of way back when KIT mutations were discovered in GIST. On the left is in a normal interstitial cells of Cajal during normal ICC development, the cells would normally require a KIT ligand that binds to the KIT receptor tyrosine kinases and activate various signaling pathways, and this would ultimately be synthesized in the nucleus, and the transcription factors or a network of them would interpret the DNA and transcribe a group of genes and make them into proteins, and eventually leads to the normal function of interstitial cells of Cajal. On the right, during the pathological condition of GIST, what we know is that when KIT or PDGFR alpha are mutated, they have this gain of function mutation or activating mutation. So they can be activated even in the absence of these ligand, the so-called KIT ligand. And the aberrant constitutive activation of these receptor tyrosine kinases can activate or superactivate some of these downstream pathways. One of the important pathways is the MAP kinase pathway. And this would continuously turn on the transcription factors and the transcription factor networks and activates a so-called oncogenic transcription transcriptomes, or a group of genes that would result in overgrowth or uncontrolled growth of the GIST cells and eventually become malignant, and then has the ability to travel as the GIST cells gain additional mutations. So this is a very simplistic way of sort of thinking about this disease. And part of the important thing is the mutations doesn't function by itself. It functions in the context of, in the case of GIST, in the context of the ICCs. Now we know, as Kerry mentioned, that we have with the ability of next-gen sequencing, we know there is all the different permutations that can happen in GIST. The majority of them harbor KIT mutations, and many of them are exon 11 followed by exon 9, and some of them would harbor exon 13, 17 mutations. And a small group of them would have PDGFR alpha mutations. These are all gain of function mutations. They hyperactivate the MAP kinase pathway. And then in some of the rare groups, the so-called wild type KIT or PDGFR alpha wild type GIST, they have BRAF mutation or the SDH deficiency, primarily happening in young adults and pediatric or children. And then occasionally they are associated with syndromes, for instance, the neurofibromatosis, or and some of them are in the carne extractus heritable disease situations, and some of them are not heritable. But it's a more sort of complex landscape of the genetic alterations, and sometimes our drugs just can't really get access to them. But nevertheless, with the realization that KIT and PDGFR alpha mutations are primarily the driver mutations in this disease, imatinib ultimately went to clinical trials and was FDA approved as a first-line therapy for GIST in 2002 after what's shown here is basically the phase 3 trial comparing 2 doses of Gleevec, 400 and 800. They're relatively equivalent, but comparing to the historical overall survival with doxorubicin, a conventional systemic chemotherapy, Gleevec really significantly improves the overall survival. And this is the dramatic responses, many of you know very well. So what's the challenge now? Right now, many of you would know personally that imatinib resistance is really the current challenge that we have yet to overcome and address. About 14% of the GIST patients, they have primary resistance, meaning that they will progress on imatinib within 3 months of therapy. And then 50% of them will develop imatinib resistance after about 2 years of being on imatinib. And many of them have secondary resistant mutations targeting exon 13, 14, 17, or 18. And Sutent, the second-line, third-line therapies have variable activities against some of these secondary resistant mutations. And beyond the secondary resistant mutations, there are other potential resistance mechanisms, understood or not well understood, that can all contribute to the overall challenge of this problem. So how do we think about it? How could we overcome imatinib resistance? This is really sort of the ultimate goal in our clinical practice and laboratory research. And what I'm going to talk about is just a couple of approaches, and then Dr. D'Angelo and DiMatteo will talk about other approaches as well. One of the things we thought about is one of the observations we've noticed in patients is really the first line Gleevec therapy is not effective enough. If we have a very effective first line therapy that can eradicate disease, we wouldn't be faced with resistance. But that's really the holy grail of targeted therapy, and I think although we have come a long way and we haven't seen, it would still be very challenging to actually have complete responses and completely eradicate disease in the metastatic setting. Surgery is still the best approach. So one of the considerations is, can we develop something better than Gleevec, more effective therapies? One is to reduce the persistence of disease, and two is maybe with better, more effective therapy, we can reduce some of the resistance mechanisms early on to imatinib. And then the second focus is really to develop better next generation of targeted therapy for secondary resistance. And as you will hear later on, a variety of pharmaceutical companies and research groups have developed a number of agents that are currently in clinical trial. And I think now is more than ever, we have a greater repertoire of these agents that we can actually match and play really started thinking about precision medicine and try to overcome some of these resistance. But there are still challenges, as I will talk about in a few minutes. So for the first session, for the first go, can we identify something that we can target more fundamentally and overcome some of the imatinib resistance, or at least delay them? A long story short is that one of the things we know for a long time is KIT mutation, or PDGFR alpha mutation, is the top signaling node that's driving GIST pathogenesis. But we also reason that there must be something else downstream, for instance, in the nucleus, that's the effector of these, that interprets whatever is being mutated or turned on upstream. And then we found a protein called ETV1. It's one of the central sort of transcription factors that drives a part of the oncogenic transcriptional program. And if you have normal KIT signaling without the ETV1, the ICC end up dying. So it's essential for the precursor cell differentiation and survival. And in the case of GIST, we know that both KIT mutation and the ETV1 are required, and the part of the and they actually cooperate together to drive GIST pathogenesis. And part of this cooperation is really through a protein stabilization of the ETV1, which hyperactivates the transcriptome. So one of the ideas is really, can we target both KIT upstream and ETV1 downstream, and then have a much more dramatic, effective therapeutic strategy? And through multiple preclinical testing, and then we have identified a combination of imatinib and MEK inhibitor that have shown synergistic effects in preclinical models. So we have moved into a phase 1b and 2 clinical trials. Actually, some of you or some of the patients or your family members have been on this trial. And this phase 1b is really to define the tolerability and define the phase 2 dose. And the phase 2 is mostly in imatinib-naive patients with the goal to improve the first-line therapy. So this is the overall design. Phase 1B we have already completed about a year ago, and recently, given the exceptional response in one SDH patient, which I'll go into a little bit more detail, we have expanded this cohort to SDH deficient GIST patients, and then the phase 2 is ongoing, and we have at least 10 patients, 10 out of 12 evaluable patients who has already had RECIST partial response compared to usually a 50% RECIST response. This is significant improvement, although a small number. And then these two patients that have not met the criteria for RECIST partial response, they are approaching. So two of the patients who eventually went to surgery and had a much more dramatic pathological response, a near complete pathological response. So these are very encouraging early data. So now, coming back to the phase 1B, we have about 18 patients in the phase 1B. Many of them have had at least 3 prior therapy, and relatively equal number of female and male all have good performance status. And these are the molecular characteristics, as we mentioned. And then in addition to the KIT, and many of them with imatinib-resistant KIT mutation, we have a few patients with some of these rare mutations, for instance, NF1 loss, BRAF mutation, or SDH deficiency. And many of them did not have a durable response, but 2 of them had a relatively durable stabilization of disease with minor shrinkage of their tumors. And one of them, this SDH deficient patient, who has remained on trial, has been doing really well. And I wanted to go into a little bit more detail about this. SDH deficient GIST is well known that's primarily resistant to imatinib. And this is a patient who has progressed initially on imatinib and sunitinib. And then at this time point, she had debulking surgery to remove the active tumors while she was on sunitinib. And then she went on to this nasitinib IGF-1R inhibitor trial. There was some preclinical data suggesting that IGF-1R pathway is activated in the SDH deficient GIST. And after progression, she came onto our trial and has remained on trial now over 3 years. She's been doing quite well. And what's shown here is really the radiographic responses. And the take-home points are really twofold. One is that some of these tumors, they respond with different temporal course. Some of them can respond relatively sooner than others. For instance, this lesion actually took about 24 months to respond. It becomes hollow. This is sort of a treatment response from this relatively dense lesion to this hollow lesion. But by and large, it's actually pretty mild response based on the RECIST criteria in terms of the tumor shrinkage. And Dr. DiMatteo took her at some midpoint to surgery. And what we saw pathologically was really a surprise. So this is when she underwent debulking surgery while on Sutent. Really, the majority of the tumor, greater than 95%, are viable. This is the liver lesion. And then this to show that she indeed had SDH deficient GIST with both. We know that she had a SDHA mutation and with a SDHB loss as part of the complex. And this is when she had been on the trial for almost 2 years. And then one of the peritoneal nodule is really showed a complete necrosis, 100% treatment response. And then one of the liver lesions that we took and biopsied, it was about 70% necrosis, and also with a significantly reduced Ki-67. So this is really dramatic responses that surprise us much more so than what we see radiographically. And we also wondered we could do mutational analysis to further analyze to see whether there could be any other gain mutations that could have potentially explained this dramatic response. But really, we didn't find anything additional other than we believe that this is all on-target effect of the ETV1 protein that's essential for the precursor and the GIST intended for the trial. So based on these exceptional response data, we have expanded the trial to allow more SDH deficient patients to go on the phase 1b, while the phase 2 is currently ongoing. And just in a few minutes, I'm going to briefly mention some of the efforts, and mostly from other laboratories as well as industry, that they have been focused on developing next generation of targeted therapy for imatinib-resistant tumors. As many of you know, that the imatinib resistance is really not just one clone, it's actually polyclonal. So even within the same individual, you can have a KIT, primarily KIT exon 11 mutation, but when one patient develops resistance, they can have an exon 13 within the same patient, but different resistant clones. For instance, this one has an exon 14 resistant mutation, this one has, this clone has an exon 17. So how do we address this? And many of the existing agents or next generation agents, they preferentially target one or the other, not both. But now I think there are several agents that are coming out that can potentially target both. And by innovative combination therapy, we may be able to get around that. And so what's shown here is really our effort, and I think now is really prime time that we have different trials that are open that can be potentially matched to all kinds of different mutations that we see in patients, especially with the ability of using impact of tissue as well as the liquid biopsies that we can, preemptively or at least preferentially understand the spectrum of mutations in each individual patient and then match them with all these different trials. And then I think some of you in the audience have already had some experiences with some of these newer agents. And these are all open trials. And what I'm not talking about here is the immunotherapy that's not targeting the specific mutations in the tumors, but rather targeting the microenvironment. And Dr. D'Angelo will talk more in detail. With that, and then this is to show that we do have the ability to, this is to compare the tumor tissues with the different mutations. And as the patients being treated, we can detect some of these emerging resistant mutations from the plasma. So this has offered us a great tool of understand the whole spectrum of mutations and then the ability to match them with different trials. I think now is really a prime time for the first time that we have the technology as well as the repertoire of clinical trials to truly do the so-called tailored medicine or precision therapy. With that, I'd like to thank all of the people, physicians on the service, and our surgeons, primary collaborator, Dr. Singer, Dr. DiMatteo, and Cristina for all of their support and continued collaboration. And then these are my lab members and my close collaborator. And last but not least, I'd like to thank the GIST Cancer Research Fund to support us and the patients, really. You made it all worth it, and then continued effort. Thank you.
Thank you for providing the opportunity to speak. It's a real true honor and privilege to be here. And really, the reason why we here doing what we do is for you, for the patients, and really not accepting the standard of care and really raising the bar and asking good questions to move the field forward. And so, I'm going to provide an overview of a few of the immunotherapy clinical trials that are open right now and a little bit of the rationale, and tell you where the field is. And so immunotherapy, actually, if you look back at the history, it's something that originated actually in this hospital dating back to the late 1800s. There was actually a sarcoma surgeon. His name was William Coley, who made some interesting observations. What he found was that when patients had infections, they were less likely to develop metastatic disease. And that was really a very telling observation. And he did various different research studies, which ultimately never moved forward, mainly because of the methodologies that he used. But what he observed was actually very important. Why not have your body fight the cancer? And the fact that the cancer grows perhaps is a failure of the immune system to recognize that cancer as being some foreign. And what drugs can we use to really make that better? And so over the last few years, there have been dramatic breakthroughs in the field of immuno-oncology, and some of the drugs that have really come to the forefront are a class of drugs called checkpoint inhibitors. And in 2013, Science, which was one of the most prestigious medical journals, deemed cancer immunotherapy the breakthrough of the year. And so it makes sense, right? Why not use your own T cells or your immune cells to eradicate the cancer? And how can we do that? And as I mentioned, checkpoint inhibitors really began to change practice. This is an example of a 91-year-old patient who had a head and neck cancer and was treated with an anti-PD-1 agent. And as you can see, she had a dramatic response. This patient was treated here in our early phase immunotherapy clinic. And this was actually a patient of mine with melanoma who had a dramatic response using combinatorial immunotherapy agents with two drugs called nivolumab and ipilimumab. And much of that work in melanoma actually was spearheaded by Jed Walchuk here. And over the last few years, when we think about cancer therapy, dating back to the 1800s, really surgery was always the standard, and that really forms a cornerstone of how we care for our patients. But since then, there's been a multitude of various breakthroughs, some which help our GIST patients, some which do not, but really all and together really form our approach in cancer care. And I highlight that over the last probably 20 or 30 years, immunotherapy is one of those pillars as well. When we think about how T cells work, how do these T cells get activated? How can these T cells get rid of infection, but more importantly, get rid of cancer? There's two signals that become important. Here's the T cell, and the T cell receptor needs to interact with the antigen or the so-called foreign particle, and that's the first signal. And then the second signal is this other interaction between these two other molecules. When these two things come together, the T cell gets activated. It's also important to know that we don't always want our T cells to be activated because that can lead to other medical problems and autoimmune conditions and other diseases like multiple sclerosis or rheumatoid arthritis or lupus. And so there's checks and balances that are in place. And one of those checks and balances is this receptor called CTLA4. When this molecule interacts to CTLA4, that signal is actually blocked, and the T cell actually turns off. On the contrary, when we look at the periphery where the cancer cells are, there's also another interaction that can lead to blockade or a decrease in the T cell response. This is when PD-1 interacts with PD-L1. And so these are just two examples of pathways that are important in generating an immune response. There are many more that we know and many that we don't know, but these are the ones that are targeted with these so-called checkpoint inhibitors. And the way to think about it is almost like driving a car. And so we have a T cell receptor. That's the ignition, and the key is the antigen. And so in order for a T cell to be activated, you need that interaction. You need to put the key in the ignition. Obviously, if you don't push in the gas, the car's not going to go anywhere, and that's the second signal. And obviously, a car that drives uncontrollably is not a good thing, and that's why we have the blockade or the brake. And so this system works quite well. But when cancer occurs, the thought is that some of these negative regulators are overactivated, and our goal is really to stop those pathways from being overactivated. And so the rationale of thinking about why the immune system is important and just actually originated in Dr. DiMatteo's lab, and he made some important observations using mouse models. He first demonstrated that when you use Gleevec, the tumor shrinks in the mice, which is important. But also, if you get rid of those CD8 cells or those T cells, you lose that decrease. And so that really was one of the first observations highlighting how important the immune system is in controlling GIST. It's not just the Gleevec, perhaps the immune system plays an important role. And when we know that Gleevec is effective, what we see is an increase in those CD8 T cells. Again, those are the important cells that we think will fight the cancer. And he tested two combination of drugs in his lab. One is a tyrosine kinase inhibitor, dasatinib, which is a drug like Gleevec, along with a drug that blocks one of those signals, a CTLA4 inhibitor. And what he found was that the mice, the volume, the tumor decreased in size. And that actually formed the foundation of one of the first clinical trials dating back to 2012. Again, this was just a reflection of how prospective thinking the lab was and the clinical team was at the time to think about combining a drug like Gleevec or sunitinib with immunotherapy to perhaps make those immune responses exist. When we treated, on this clinical trial, we treated about 28 patients. 20 had GIST. What we found were that there were a fair amount of GIST patients who had some evidence of disease stability, but it was not good enough. I mean, and really the time that patients remained on treatment was about 3 months, which is similar to what you would otherwise see with that drug alone. So I think what we learned from that trial is that a few things. One, dasatinib was not the best drug to use. And that was not our first choice. I think there had been a lot of interest in using Gleevec. However, we were unable to get support from the pharmaceutical company at that time for the Gleevec. And that's actually a very important point where organizations like this one can actually help with funding and rally interest and lobby for the investigators to perform really rational clinical trials. The other thing is that ipilimumab perhaps was not the best drug to activate the immune system. And since then, there are drugs that actually appear to be more effective. And so while this trial may not be a so-called positive trial, we actually learned a lot, and it formed the foundation for future and what we think are more effective clinical trials. And so, again, a lot of this work stems from Dr. Di Matteo's lab. He went back and looked at a compound called PLX3397, which is open in as single agents and is in various combination strategies alone without immunotherapy as well. We think that drug actually may be more effective in shrinking GIST tumors who have some specific genetic alterations. But he also combined that drug with an anti-PD-1 drug. And as you can see here, when you combine that drug with the anti-PD-1, this seems that the GIST tumors are more likely to shrink. And so that is really the rationale of this clinical trial, which actually is open and actively accruing right now. We've enrolled 4 patients. The study's been open for about 2 months or so. This other clinical trial originated back in 2015 and initially was open just to sarcoma patients, and it excluded GIST. It combined 2 different immunotherapy compounds, nivolumab with ipilimumab versus nivolumab alone. And given the high interest in exploring these agents in GIST as well, we were able to convince the Alliance Clinical Trials Oncology Group as well as NCI and CTIP to expand in GIST. And finally, we've gotten that approval, and we're hoping to open that arm of the trial sometime in the late summer. Finally, another important pathway in GIST is the IDO pathway. And IDO is a molecule that actually decreases T cells.